So next we have Asha Das, who's going to talk to us about treatment of recurrent high-grade glioma patients with the retroviral replicating vector Toca 511 and Toca FC, giving durable responses and survival lasting 3 years or longer, immune mechanisms and molecular analyses of the tumors. Oh.
Looks like it's actually.
So obviously I'm not Asha Das.
Sorry, I didn't see you coming.
I'm Doug Jolly from Toca, and I'm standing in for Asha, who was called away for a clinical emergency. So she apologizes for that. So I'm going to talk about our recurrent high-grade glioma in this long, complicated title, the retroviral replicating vector, and treated with Toca FC. So let me go ahead and work this. Okay. So here's what I'll tell you. I'm going to outline some phase 1 data from patients with high-grade glioma that we've treated. And this is a long-going trial, and we published it originally in Science Translational Medicine in 2016, but the results are continuing to hold up. And we'll tell you a little bit about the preclinical immune-mediated mechanism of action, and then what we've been able to do to measure clinical immune responses, and the correlation with those responses with clinical outcome. Then a little bit of molecular analysis of tumor in the blood, and then I'll tell you a little bit about the phase 3 recurrent high-grade glioma trial we're currently running. So this is the agent we use. It's a vanilla amphotropic MLV with a yeast cytosine deaminase gene inserted into the genome of the virus. So it's carried along with the virus. And the key thing about this, it's kind of delayed oncolytic virus tactics where you get virus replication, but the virus doesn't kill the cells until you give 5-FC, and then it turns into 5-FU, and that kills the cells. But also, it appears to drive antigen stimulation against the tumor that's previously suppressed. So the way that it's tumor specific is, we think it's because the defects in the innate immune system of the cancer cells, and the virus infects only dividing cells. Just to give you a snapshot of the specificity, on the left-hand side here is there's a mouse tumor in the brain, a glioma, and the brown is the tumor, and the left is the parenchyma, which is unstained. It's stained for the virus. You can see the virus is very specific for the tumor here in this situation. More impressive, on the right-hand side, is if you go IV into a mouse model seeded with liver mets that are marked with luciferase, and then you go in with our replicating retrovirus that's GFP marked, then you can see you get coincidence of the GFP signal to the luciferase signal, and nowhere else. So the specificity here is very nice, and the key advantage of this system. So this leads to local high levels of 5-FU after prodrug administration. This is just illustrated in this model here with a rat glioma, where you can see high levels of 5-FU in the column with 5-FU in it, in the tumor, but in the plasma it's much lower. Whereas the other way around in human trials with colorectal cancer, where 5-FU is used, and you can see you get high levels in the plasma and low levels in the tumor. And the high levels in the tumor, we think, have advantages in terms of the immune stimulation for the anti-tumor effect. So I'm going to talk about high-grade glioma. High-grade glioma is a nasty disease. It's a typical course of high-grade glioma currently with standard of care treatment. So after you get diagnosed with a brain tumor, which happens because you got dyskinesias or headaches or something like that, go to the doctor. You may get told to take Advil for a couple of weeks. If that doesn't help, then they give you an MRI. Then they surgically operate to take out the tumor if they can, either partially or totally, give surgery, radiation, and chemotherapy. And the tumor goes away, but it comes back again almost all the time, about 8 months later. Then you're in kind of trouble, as you were before, but even closer. And there are some approved drugs, but none of them do much. And you have about 8 months on average to live at that point. So very nasty, depressing disease. So we've done 3 phase 1 ascending dose trials evaluating the delivery approaches of recurrent high-grade glioma by resection, intratumoral injection, or intravenous injection. By resection, resect the tumor and then inject the walls of the cavity in the brain, because this is a very infiltrating tumor, and there's always tumor left behind. And intratumorally, we take patients and just inject the tumor directly. In IV, we injected the virus IV to see where it got to the tumor, then whipped it out about 2 weeks later, and then gave it again in the bed of the tumor. So in terms of adverse events, it's very well tolerated. You can see here that the low incidence of grade 3, grade 4 related adverse events. And there's two agents here. There's the Toca 511, which is the virus, and Toca FC, which is extended release 5FC. And you can see that the 5FC is actually a drug that's been on the market for the last 40 years. We made an extended release version of it so it's easier to take, and because you have to take it 4 times a day if it's immediate release, which means you have to wake up in the middle of the night and take about 15 pills because high levels of 5FU you have to get to, 5FC you have to get to in the bloodstream. So you can see the very low levels of treatment-related SAEs and very low adverse events of any kind leading to death. In terms of survival, the overall survival in the resection trial is a little better than the other trials, but they're all better than the average survival on lomustine, which is about 8.5 months. We get 14.4 months median overall survival for the resection trial and comparable results for the other routes of administration. But what's most interesting is the survival of a small group of patients, but I'll get to that in a minute. This just shows you, in some of the patients, there's blood positivity, about 10 to 30%, depending on how you administer it, that goes away after about, most of it goes away right away, but about 10 to 30% get a peak of 4 to 8 months, 4 to 8 weeks out, and we'll be able to sample blood and ask if there's anything different about the clonal, is there any clonal expansion by PCR integration analysis. We've also looked in the blood, in the tumor to see whether that happens there, and also looking for evidence of the tumor expanding or with subsequent infection of other tumor cells. You can see in the middle there, there's very little repeat integration, which is reassuring, and the red is the blood and the blue is the tumor. And these are all the samples we were able to measure in those subjects. On the right-hand side is just showing you roughly where the integrations are by class of gene they're next to or close to. And although, and actually interestingly, this is different in the PBMCs in the tumor because the integration sites are pretty typical. And we have one patient analysis that we got a patient autopsy. We'd like to thank the patient and the doctor for allowing us to take these samples. But you can see here on the left-hand side is DNA analysis of the tissues from that patient. All the positives that are above LLOQ, which is low limit of quantitation, are in the brain. And the right-hand side is RNA, which is active virus, essentially. And you can see that's only in the brain. Interestingly, the original injected tumor still has virus in it, but also a non-injected part of the tumor, which either means the virus spread or it went around the back. So now I'm going to talk about the resection trial in particular because that's where the most interesting results are. This is what's called a swim lane result. These are individual patients in their survival, and the ones with the green star beside them are still alive. And this is 40 months out and more. And the longest survival is now over 5 years after treatment. This is pretty spectacular, in fact, very exciting for patients who are normally supposed to die within 8.5 months. What you can see with those orange dots in the beginning is a stable disease. Then you get further on, you get partial response or complete response. Some patients go through partial response, then complete response. Some patients go through complete response right away. And on the green line on the left-hand side is the kind of expected survival from historical controls. And we actually bought a control arm for a GBM study that someone else had done to get individual patient data so we could match the patient to the group we were looking at. And so the most interesting thing here, apart from the long-term survival, is the fact that the responses occur over a long period of time, 6 to 19 months overall, and there's one complete partial response that turned into a complete response about 30 months out. So this is the trademark of immune response against the tumor. So just to give you an example here, I'm probably not going to go through this in detail, but this is the whole progression of the tumor from the beginning, where there's tumor, it's growing, it gets resected, and of course when it's resected, they try and take out all the enhancing tumor. But the tumor progresses, and interestingly, we inject the virus and let it give 6 weeks for spread. And during that time, the tumor almost always recurs. And you can see it when you treat with 5FC, and then you can watch it go away. You get a partial response and then a complete response. And the whole process takes about 3 years in this case. This is a long-lived GBM study. So this is a progressive GBM, so this high-grade glioma is grade 3 and grade 4 glioma. Grade 4 is GBM, and IDH wild type is a type of tumor that normally is is more aggressive than normal. So just a quick word about what the preclinical mechanism of action is. We've done a lot of experiments here, and we've published these, so I'll just summarize it here. We know that 5-FU is myelosuppressive normally when given systemically, and it's no exception here, but here you're destroying the myeloid cells that are within the tumor. The tumor is attracted to control the immune response against the tumor. So you're eliminating myeloid-derived suppressor cells or tumor-associated macrophages, and the T cells get initially depressed and then come roaring back again once the myeloid cells are out of the way. So we think this is a key mechanism of action that's happening in the human patient tumors, and we've seen this both in intracranial, subcutaneous, and liver metastasis models. So it's a general phenomenon, although not completely general, in all cancers, and we're interested in using that in other cancers. So here's what we've been able to do clinically to measure immune responses to the tumor that appear to be correlated with outcome. First one is the mutation frequency. So this is exome sequencing analysis of the tumors before treatment compared to survival. Survival is on the bottom, and the patients in blue are alive. And on the top is the exome analysis showing the rate of mutations per cell. And this is absolutely, about 200 is about the average number you get in a GBM. You do get high mutation rates in some patients who are treated with temozolomide, and you can see 2 on the left-hand side there, but it's got no correlation with outcome. So these are not high antigen load tumors, which is interesting because those are the ones that are difficult to treat with checkpoint inhibitors or other immune stimulation. So there may be a chance of turning some kind of tumors that are non-responsive to those kind of agents into tumors that are responsive to those kind of agents. So we're also looking for cytokine measurements in the patients. And the goals here are to see if the immune signaling in responders versus non-responders, but also since it's blood and not tumor, you can follow it closely, and looking for a marker that would tell you if survival is predicted by an immune response that's detected in the serum. We looked at 25 patients, 6 complete responders and 19 progressive disease and stable disease. This is an individual cytokine panel. This on the left is E-selectin. This is not significant, but it looks interesting. On the right is MIP-1 beta, and higher MIP-1 beta predicts clinical survival, improved clinical survival. More spectacularly, if you do principal component analysis, that is pooling sets of cytokines. We screened 40 cytokines with these experiments. You get highly significant once they're age and stage adjusted for both increase above median and below median on the right-hand side for a group of about 10 cytokines each. So this, in our mind, shows there's immune response going on. The kicker is that about 15 months is not very quick, and about where all the tumors start to disappear. So it doesn't give us a marker we can follow and predict outcome very easily. We have looked at the T cells by deconvoluting sequence analysis, and you can see there is a increased fraction of tumor-infiltrating T lymphocytes in this responders compared to the non-responders. So in that respect, it does conform to the normal picture of hot versus cold tumors. So just a quick word about intravenous administration, because it's interesting data. And this is just anecdotal data showing the cytosine deaminase in the brain tumor after IV administration, and the GAG protein, which is a viral protein, also there. You merge the two on the right-hand side. You can see they're overlapping. And so we do get virus to the tumor in these patients. It's patchy, and we think that you just need enough transduction to get enough transduction to get immune response going. This is the phase 3 trial that's ongoing, and we've about 75% enrolled it. It's matched to the group that I showed you in the swim lane, and the control group is chemotherapy of our standard of care, which is lomustine, temozolomide, or bevacizumab, which is a monoclonal antibody called Avastin, against Toca 511 and 5-SC. So So the conclusions, the phase 1 trial showed overall survival comparable in both surgical and non-surgical settings. Treatment was well tolerated. No evidence of clonal expansion of vector-infected cells. In the IV study, we saw vector deposition in the tumor. The resection studies showed strong links between durable responses over greater than 6 months and survival. And immunological correlates to responses were observed in the tumor in the blood. Tumor selectivity seen in animals were maintained in one human patient that we were able to get an autopsy from. So the Toca 511 and 5FC activates durable T-cell mediated responses that are preclinically, and actually, it's interestingly, the CD4 cells appear to be more important than CD8 cells here, although we haven't unraveled that. But what's common is local myeloid cell depletion, although it depends on the myeloid population of the tumor. Tumor selectivity in animals are maintained in the human patient, and the phase 3 trial is enrolling. Plan to complete enrollment by the end of this year with 380 patients enrolled. Because after we've got breakthrough therapy, we're allowed to form a seamless phase 2, phase 3. In other words, include the phase 2 patients in the phase 3 trial. We're planning to expand newly diagnosed high-grade glioma and carry out further studies in other solid tumors. With that, I'll stop and say thank you.
Yes.
I have a quick question. So which cytokines were associated with outcome? You showed the complex score. Are there certain cytokines there that were more prominent than others?
So we're busy analyzing that because the data is pretty recent, but as I saw, MIP1 beta, you saw the two that looked the best actually. So you have to do the statistical analysis and group them. So what you do by ranking analysis is you just group them into all the groups you can think of, and then see who correlates the best, and so there's 10 cytokines in each panel. I can't tell you which ones they are off the top of my head, but we're publishing that soon.
Yes.
Hi, Doug. Karen
Hey.
from City of Hope. How many times are you giving the retrovirus? Just once?
Just once, yeah.
And how many times how long are you giving the 5FC?
So the typical course is about 3 to 6. So as I mentioned, we give Toca 511, then wait for the beta virus to spread, give 5FC, and we give that sporadically, typically 1 week out of 6 weeks. And so interestingly, if you take them off in the animals after 3 cycles, they appear to be cured. We try to keep them on for 6 cycles in the patients. But then the long-term survivors, half of them, actually it's interesting, half of them want to take the 5FC all the time. The other half don't want to know they ever had a brain tumor. And so they don't take 5FC.
So the virus stays even through the 6 rounds of 5FC. You're not adding more virus?
No.
Okay. Thanks.
So Doug, it's pretty exciting with the phase 3 trial ongoing. Just to clarify, so that's an injection of virus into the resection cavity post-removal. And then you're looking at survival as your outcome, overall survival. So how long are you going to have to wait after you finish accrual in order to take a look at the data and read out?
So we're going to take an interim look this year about we should have data in the second half of the year. We don't expect to see much, but we hope to get a okay to continue. We have an interim look next year, and then we are hopeful to see something, and then the final look is in a year after, or actually probably, because the enrollment's gone so well, it's probably going to be towards the end of 2019 for the final look.
Okay, thanks very much.